Hi, my name is Ann Edenfield-Sweet. I'm the Executive Director and founder of Wings for Life International. And tonight we have a very interesting topic we're going to talk about. It's all the myths and the truths that go along with medicated-assisted treatment. And Athena Huckabee is our speaker tonight, and she has her master's degree in public health. And she's been doing this for about 10 years, and she's got a very interesting story why she got involved in this in the first place that she's going to share with us. But tonight she's going to talk about buprenorphine. And so when I first saw that, I thought, buprenorphine, what in the world is this? So she's going to explain all about this. So those of you that are like me that don't understand these things are going to be more educated and more aware. So I am so excited. Athena, thank you for joining us tonight and share those common myths and facts.
Great. Thanks so much, Ann. So yeah, my name is Athena Huckabee, and I work with Ideal Option, which is a low-barrier clinic for medication-assisted treatment. We have several locations throughout the state, including Las Cruces, Albuquerque. We just opened Rio Rancho today, in fact, and we also have a location in Farmington. So one of the things that I just wanted to say about myself, that I'm a person in recovery myself, and this is a topic that's very near and dear to my heart. I work in areas that are not incidental to my lived experience. So I just wanted to make that clear as well, that I have education around this topic, and then I also have gone on the recovery journey myself. So I hear when I'm working in the community a lot of myths around medication-assisted treatment and how it works and what it does. So I just wanted to take an opportunity while I have this amazing chance to speak with Wings for Life to tell you about these myths, also tell you a couple of facts, and then of course I'm happy to answer questions as well. So myth number one, the myth that I hear the most, is that medication-assisted treatment replaces one drug with another. When we're talking about medication-assisted treatment, we're talking about methadone and buprenorphine for opiate use disorder. You might know those as sometimes buprenorphine is called subs or Suboxone. Suboxone is one of the brand name types of buprenorphine, but buprenorphine is the generic of the drug. So hopefully that makes sense. It's like the difference between ibuprofen and Advil, right? Suboxone is a brand name, but the name of the drug is buprenorphine. So I don't think that people really understand that opiate use disorder is very different than alcohol use disorder, for example. Abstinence works, just not drinking can work pretty well for alcohol use disorder, even though there are medications to help with that. But with opiate use disorder, fewer than 5% of people achieve recovery without a medication to help them along. Virtually all patients relapse within 30 days of leaving inpatient rehab or jail where medication-assisted treatment wasn't available. And many people relapse on their first day out, and some people overdose and die. So this is one of the reasons that we give Narcan out now when people get out of jail or prison, because we know that people coming out of jail or prison are 12 times more likely to overdose than at any other time in their lives. So it's really important that they have the overdose recovery antidote when they're getting out. But any period of abstinence actually leaves people more vulnerable to overdose and death. So it's just really important to understand that medication-assisted treatment protects people from overdose, allows their brain time to heal, and makes behavioral health treatment more effective. So abstinence-based treatment for opiate use disorder is pretty ineffective. It's got a 90% return to use rate. So I just think it's really important to understand the numbers so that people understand how these drugs work in the brain. So while counseling, group meetings, mental health treatment, and other types of emotional support are critical for recovery, the rewired brain circuitry of an opiate use disorder patient requires medication. Basically, when you use opiates for a long time, the receptors in your brain sort of get broken and need a little bit of time to heal. And the medication-assisted treatment allows your brain some time to do that. One of our founders, Dr. Jeff Allgaier, says, without the right medication, the rest doesn't matter. So I hope that talks a little bit about the replacing one drug with another thing. There's so many things that I could say about that. And I just think it's such a pernicious myth that really stops people from being able to access effective treatment to help them recover. Myth number 2 is that you can get high on Suboxone. So Suboxone or buprenorphine, right, they're the same thing, are what's called a partial opioid agonist. So what this means is, I'll describe it, I heard Dr. Snehal Bhatt describe it once as like a door. So if your opioid receptors are like a door in your brain, if you take a full agonist like heroin or oxycodone, it opens the door all the way. If you take a partial agonist like buprenorphine, it only opens the door halfway. So it is really difficult to get high on it. And it's got what we call this ceiling effect, right? Where the door is only gonna open halfway, and that inhibits feelings of euphoria. One of the things that we see happen when people first go on buprenorphine is that they will take it and they sort of feel like it's not working because they don't feel high. So then we ask them about, well, what about your withdrawal symptoms? How are those feeling? Oh, well, I don't have any withdrawal symptoms. That's ideally how you should feel, right? No withdrawal symptoms, but not high, just sort of like even keel, right? Almost like it allows you to function. So if people are on the right dose of medication, it doesn't make them high or produce euphoric effects. And it's also very hard to overdose on its own. Most of the time when we see people overdose on buprenorphine or Suboxone, it's because they mixed it with alcohol or Xanax or another drug. So it's got, again, this ceiling effect where it doesn't impact respiratory depression as much as other opioids. So if someone, there's always a caveat, right? If someone who's opioid naive, meaning I have not taken an opioid painkiller in, I don't even know how long, right? I have no opioids in my system and I don't have any kind of a dependence on opioids. So if I were to take Suboxone, I might feel some euphoria. But for people with an opioid use disorder, this very rarely happens. It kind of just allows you to function. So Suboxone also, is important to note, contains, so again, Suboxone, which is the brand name of buprenorphine, is a buprenorphine and naloxone product. So it has buprenorphine, and it also has naloxone, which is the opioid blocking medication, and that causes withdrawal symptoms if someone tries to abuse it. So basically, the naloxone is in there. People think that it absorbs through the system when they take their Suboxone, but it actually doesn't. Where the naloxone comes into effect is if someone were to try to inject it. So at that point, if you melt it down and try to inject it, the naloxone gets activated and it blocks the opioid effect. So that's one of the reasons that Suboxone is a pretty safe type of medication, because it's got that sort of, what do I want to say, like you can't mess with it too much, right? And I liked this quote from one of our patients. He said, "Suboxone allows me to think about my day and my life and stay in the present. You don't get high at all, you just get to think." So I really liked that quote. I thought that was super helpful. Myth number 3. So I actually hear this myth in 2 forms. One is that you can never stop taking Suboxone. The other myth that I hear is that you should only take it for a few days and get off of it immediately. So both of those things, are kind of untrue. It depends on the unique situation and the history of drug use with each patient. So for example, if someone has had an opiate use disorder for 3 years, they could probably taper off the Suboxone in 3 years or less. If somebody has had an opiate use disorder and has been misusing heroin or fentanyl or other opioids for a very long time, it might take your brain receptors a longer time to heal. So it's very individual. We really recommend, the American Society of Addiction Medicine recommends that people stay on it for a minimum of a year. And then it varies based on the person. So if someone's been on opioids for decades, like I said, they might need Suboxone for the rest of their life. But that just means that you're dependent on a medication the same way a diabetic is dependent on insulin, or the same way that somebody that takes an antidepressant is dependent on their antidepressant, or the same way that someone who takes pills for their high blood pressure is dependent on those. Many of us take a medication every day that we might need for the rest of our lives, and there's no shame in that. So, and I like this quote again from Dr. Allgaier: if you have to take a pill to feel normal for the rest of your life versus using all sorts of drugs and committing crimes, then that's what you do, right? So it's an option for people. However, if people want to be on it for a few years and get off of it, our physicians can help people do that. You can taper off slowly and with the help of a professional, and that can work. So, I think all of the ideas that you should only take it for a very short period of time or you have to take it forever, really the truth is somewhere in the middle. I hear this one a lot. People say this about methadone too, that buprenorphine is harder to quit than heroin, right? So don't even go on that stuff because it'll be harder to get off of than what you're on. Well, first of all, I think the landscape has changed a little bit with the fentanyl, right? We're really not seeing very much heroin in our communities these days. It's really more of the fentanyl. And that stuff can be pretty hard to quit. As far as Suboxone goes, when our patients at Ideal Option are ready to discontinue their medication, we can slowly taper the dose and frequency down. And if it's tapered appropriately, people shouldn't experience withdrawal symptoms. And usually also what happens is when people come into our clinic, they're started on a higher dose, and then they can sort of taper down and get on a maintenance dose that they'll stay on. This is because, like I was saying about the brain and giving it some time to heal, the brain gradually sheds the extra opioid receptors that it had developed in response to the daily dopamine flood. So basically, when you're using opioids problematically every day, our brains are what they call neuroplastic, right? We used to think that your brain didn't make any changes, right? That once you killed brain cells, they were dead forever, and that once, changes had happened in the brain, they could never go back. But we now know that the brain is neuroplastic, and it adapts to situations. So when people are overusing their opioids, your brain actually grows extra opioid receptors, and that's one of the reasons that you develop tolerance and withdraw. So when you use the Suboxone appropriately, it gives your brain time to shed those receptors. And what that means for you is that you feel a little better. So I think it's just important to know that tapering should never really be a quick taper. So we see this a lot where people just quickly taper off the drug and are done. Actually, the longer the taper, the better your chances of success. So if we taper it very slowly, incrementally over time, then that helps to minimize withdrawal symptoms and it helps to contribute to the success of folks. So yeah, I think that the idea that it's harder to quit than heroin is not true, and I think that also doesn't take into account the relapse rate, right? The idea is that once you're on Suboxone for an appropriate amount of time, either you take it for a long time or you slowly taper off of it, and that is better than just quitting cold turkey, right? So that's the idea around that. Myth number 5, I hear this about methadone clinics too, that Suboxone or buprenorphine clinics attract loitering and crime. So we just haven't seen that type of behavior in our clinics. People might come, they might charge their phone, they see their provider and they leave. People like the environment in our clinics. I've been told that it's very calming and peaceful. Like this patient says, the whole clinic is like a spa. I don't know about that, but we have nice furniture and we have plants and we have good lighting and we try to be kind, so it's not like it's, green painted cinder blocks and it tries to be a welcoming environment. Myth number 6, Suboxone ends up on the street. So this is one I hear a lot when we talk about jails and prisons, right? People are like, well, it sells for $100 a strip in jail. I understand that that's what's happening, but I think that the reason for that is because we aren't offering medication-assisted treatment in jails, and so they've actually created that black market. if that makes sense. It's not available, and so people want it very badly to ease their withdrawal symptoms. Some patients, of course, do sell or give away their medication, but the majority of our patients take it as directed. And also, we check the urine to make sure that they're taking it. So we test for what's called buprenorphine metabolite, meaning that we test to see that it was metabolized and it went through their system and came out in their urine. So we have a trust but verify protocol. The other thing to note is that when Suboxone is diverted, it is most commonly sought by people with opioid addiction to alleviate withdrawal symptoms, not as a way to get high. Our clinic, Ideal Option, we have a lot of clinics in Seattle. Apparently, Suboxone is easy enough to get in Seattle that it only goes for about $5 a strip on the street. So it's easier actually for people to just get into a legitimate program and get a legitimate prescription, it's because it's just so widely available. So it doesn't sell for very much, so people aren't motivated to sell it. So that's controversial, but I do agree that when it's diverted, it's used for people that need help with their addiction. It's not just diverted so that people like myself that are opioid naive can get high. Myth number 7 is that detoxing in jail helps people to get clean. So we already talked about how people coming out of jail or prison are 12 times more likely to overdose than other people. Failure to treat opiate use disorder during incarceration has very serious consequences. There have been cases of illness and death from opioid withdrawal during incarceration. It's pretty hard to die from opioid withdrawal, but sometimes people get extremely dehydrated and may actually pass because of that. There's also issues, even with custodial care. Opioid withdrawal causes vomiting and diarrhea and lots of other GI distress. It's messy and, can be avoided. There's a risk of injury and suicide during incarceration, and it's a burden on the staff. Like we had said, there's a high risk of overdose death after release, and then there's high rates of crime and recidivism post-release. We run some jail programs in the Benton County Jail and some other places in Washington, and we see that the people that go through our program and get treatment while they're in jail have much lower recidivism rates than people that don't get that treatment. So I think that's really important. It doesn't actually help. I would love to hear some other myths in the chat if you all would like to share. And then I think I only have a couple minutes left, so we'll go over a couple of facts. Fact number 1 is that opiate use disorder is a chronic brain disease. It causes changes in the brain that lead to self-destructive behaviors and compulsive drug use. And like other chronic conditions, opiate use disorder is caused by a combination of behavioral, environmental, and biological factors. Genetic risk factors account for about half of the likelihood that an individual will develop an addiction. Another factor is, we know, adverse childhood experiences. So things like having a parent in prison or jail, sexual abuse as a child, things like this can contribute also to opiate use disorder. Chronic exposure to opioids results in brain abnormalities, and those abnormalities lead to addiction, also known as opiate use disorder. The second fact that I want to emphasize is that opiate use disorder is treatable with medication. Medication-assisted treatment is the recommended treatment modality for people with opioid addiction. It reduces cravings. It blocks the effects of opioids if those are used while on the medication. So if people are on buprenorphine and choose to use opioids anyway, the buprenorphine is going to block that effect and not allow them to get high, and also protects them from overdose. So I think that's really important to know. It prevents withdrawal, which is awful. Nobody likes to go through it. And it helps to restore normal brain function, including memory, concentration, decision-making, and thinking. So I think that's all really important to know. And then just very quickly about Ideal Option, I just wanted to say that we have several locations in New Mexico, as I mentioned, Albuquerque, Farmington, Las Cruces, and our newly opened Rio Rancho clinic. So that just opened actually today. So we're going to be taking patients very soon. Now, as a matter of fact. If you are viewing this and you work for a jail or a prison, or you work for, a behavioral health, or maybe you're with Wings for Life, you can call this number, which is 844-GO-IDEAL. I want to be clear that this is our referral hotline. This is for people that are referring a patient. This is not our patient line. So if you are a patient and you want to call and make an appointment, you can go to our website, which is idealoption.com. And then I just want to emphasize the model that our clinic operates under. So we're what's called a low barrier clinic. That means that we want it to be easier to come in and book an appointment with us than it is to go to your plug and get your usual thing from the dealer. So in that vein, we never run a wait list. Patients are generally scheduled for their first appointment within 24 business hours or on the same day if possible. Obviously, if you call on a Friday afternoon, we're probably not going to be able to get you in until Monday. It was very funny. On Good Friday, I actually had several people call me at 4 o'clock on Good Friday, and I could not get those people in until Monday, so just something to think about. We also accept walk-ins at most of our clinic locations. So again, we'll take you that day. You may have to wait to be seen, but we'll take you. So, just be patient if you do decide to walk in. It is better to give a call ahead. We try to eliminate any financial barriers that we can. So we take all New Mexico Medicaid plans. 70% of our patients have Medicaid, so that's the majority of our patient base. We also accept most Medicare plans, and we have financial assistance available for folks. You can go to our website, idealoption.com/insurance providers, and check to see which insurance we take. And of course, you're always welcome to give a call ahead. As I mentioned, our clinics don't have any overnight stays, so we're not an inpatient facility of any type. It's just like a regular doctor's office. So basically, you come in, you wait to see someone, you see a medical assistant, they take your vitals, they ask you some questions, and then you see the provider. They're located conveniently, and the idea is that actually many people with opiate use disorder don't actually need inpatient treatment. If they can get on a medication that will help them with their withdrawal symptoms, then they can, go to something more like an IOP, which is intensive outpatient treatment, where they're seen during the day, or they can have a therapist or engage in their support groups. But the idea with MAT also is that patients can see their family, keep their jobs, and build new routines. So sometimes when we send people away to inpatient clinics, they get well while they're there, and then they come back into the environment and, kind of fall back into old behaviors. So I think that the no overnight stays thing is actually helpful for people. And then finally, we have no penalties. So what that means is that we understand that addiction is a chronic, relapsing brain condition. That means that while slips or relapse will trigger a review of a patient's treatment plan, patients are never penalized or expelled for return to use episodes. So what does that mean? If you slip, we're going to take a look at your treatment plan. Is your dose high enough? Are your cravings well controlled? Are you engaging in support groups? Is there other help you need? Sometimes we'll see that people are not taking their buprenorphine. Maybe they need to come in for observed dosing, and meet with the provider and take it in front of them. We'll try to work and see what works for you. We also don't have sometimes people have something like a 3 strikes you're out rule, or they'll consider people treatment failures. So maybe someone will come and try with a clinic a few times and not be successful, and then they'll say, well, I guess we're not the right one to help you. We allow people to come back as many times as they want to try. I know that relapse was definitely part of my recovery. I have friends that, tried 13, 20, 30 times to get sober and are sober today, so I think people need all of those chances. That concludes my presentation for today. I would love to stay engaged on this topic. Please feel free to reach out to me. And I think that's all I have, but I thank you so much. And then we have Anne.
Well, Athena, thank you so much. Wow. Oh, I learned so much. And this is going to be so helpful for so many people. I know, people like me here, right here. So very, very grateful for everything that she had to share. Now, you know, I always like to close with a story. So I was trying to think, what kind of story did I have that would go with this one? So this story is called It's Time to Quit. And the author is unknown. So number 1, 18 reasons why you should quit. Quit arguing with people about the same old foolishness. Respect their position and keep it moving. Quit telling people your secrets when you know they are not going to keep them. Quit trying to pull people on your journey and you don't want them to travel with you. Either they believe in you and value you or they don't. Quit complaining about things you can't and won't change. Quit gossiping about other people. Minding your own business should be a full-time job. Wow, that's a good one, huh? Quit blaming others for things that in the big picture aren't going to matter 3 weeks from now. Talk solution and then implement them. Number 7, quit eating things you know are not good for you. And if you can't quit, eat at least smaller portions. Number 8, quit buying things when you know you can't afford them. Very good advice. Number 9, quit staying in unhealthy relationships. It is not okay for people to verbally or physically abuse you. Number 10, quit letting family members rope you into the drama. Tell them you don't want to hear it and quit spreading the drama. Number 11, quit trying to change people. Doesn't work. They have to do it on their own. Number 12, quit the job you hate. Find the job that fuels your passion, however, before you quit that job that you hate. Number 13, quit volunteering for things that you aren't getting any personal fulfillment from. And 14, quit volunteering for things and then failing to follow through with your commitment. Number 15, quit listening to the naysayers. Quit watching the depressing news if you're going to live in doom and gloom all the time. Oh boy, we'd have to turn off all TVs if we were going to do that these days, wouldn't we? Number 16, quit making excuses about why you are where you are or why you can't do what you want to do. Number 17, quit waiting on others to give you the answers and start finding the answers for yourself. If what you're doing isn't working for you, then quit it. And lastly, number 18, quit being afraid and start living your life. Create the life that you want. If you want something different than what you've had in the past, of course, you must admit that what you've done before is not working, and then you have to do something to create the experience that you want. So it's time to quit some things for all of us, right? So I hope this was helpful. Now, if you are with us on Facebook or YouTube, this is the end of the program. If you are with us on Zoom, oh boy, we're going to go right into breakout rooms. You're going to be able to talk to Athena. You're going to be able to ask all those extra questions that you had, and she will be with us to help us with all those questions. So thanks so much for joining us tonight. Every Monday night, 6 o'clock p.m. Mountain Time. Hope to see you next week. Thanks so much. Good night.